So welcome everyone, it's 1 o'clock and as promised we are now having our webinar focusing on the acute and emergency presentations of children with possible PIMS-TS. Thank you very much to everyone who's joined us. We're going to have a very quick introduction, so we're going to do a short series of presentations focusing very much on these children presenting to the acute emergency departments and acute general peds. There's going to be some input from Liz around the spectrum of PIMS-TS, and then Simon Clark's very kindly agreed to talk about the acute abdomen in the context of PIMS-TS, which has presented a number of diagnostic challenges. And then Liz is going to talk about children who require transfer and the initial stabilisation of those children. And then following that, there's going to be an opportunity for a panel discussion where we'll be able to take any questions. So I would ask those of you online to hold your questions until the second half of this hour. And then we'll hopefully be able to work through them all. I would also say that this is very much focusing on the initial presentation and stabilisation of children presenting with PIMS-TS. Those of you who aren't aware, we had a much longer webinar a week and a half ago, which looked at the ongoing care of these children, and we won't be covering that in this presentation, but we can signpost you to the recording of that presentation should you wish to do so. I think Kate's going to just give a quick set of housekeeping rules.
Hi everyone. So yes, thank you again for joining us. There's only a few housekeeping rules. I mean, what's fortunate about doing it online is you don't have to tell everyone where all the facilities are. So obviously this is a webinar function, so you are automatically muted. So we just ask that you please put your questions into the chat box, which you should find at the bottom, and we will automatically feed those through to the panel. And then just to say that, as before, there is a maximum occupancy, unfortunately, to this webinar, as we strive to host these free of charge. However, we are also going live on YouTube. So for anybody that unfortunately reaches the maximum, you should be redirected there, or your colleagues should be if they do ask you. That's it from me.
And just to say, we will also be recording this and we will share the recording afterwards. So if you have colleagues who aren't lucky enough to get on this live, don't worry, we can share the recording afterwards. That's it from me, and we'll go on to our first presentation.
Good afternoon. Good afternoon. My name's Emily Cadman. I'm one of the Paediatric Emergency Medicine Registrars at St Mary's. And I'm wanting to tell you today about a patient that I looked after in our department a few weeks ago, with the hope that she will stay in your mind to illustrate some of the points we're going to be discussing over the next hour. So just picture the scene, if you will. About 8 o'clock in the evening on a late shift, I was beginning to think I was getting a bit hungry. I might go and get my dinner out of the fridge and go and eat it on the balcony, admiring the scenic view that you can see in front of you from the staff room. Just as that thought was crystallizing in my mind as an excellent idea, I heard these words: "Emily, can you just come and assess this girl with a systolic of 55? So there went dinner plans. And I went into resus and caught up with both the triage nurse and the patient's mother to hear the history of 5 days history of fever, 3 days shortness of breath and cough, 2 days of a rash that started off blistering on her arms but had evolved now into a pale pink rash, 2 days of red eyes, and just this afternoon beginning to complain of abdominal pain and profuse vomiting." Now, the triage notes say that she was taken direct to resus, but just to really paint the picture for you of the girl that was in front of me, she'd walked herself from triage to resus. In the same way, she and her mum had presented at the front door of A&E. They hadn't come in as a blue call via LAS. She'd walked up that ramp outside St Mary's and walked herself to resus. And when I went into resus, I saw her sitting up, alert, talking to me. So carried out an initial A to E assessment and found her tachypneic, but saturating well in room air, tachycardic with that blood pressure of 55/38. Centrally, she was very well perfused, but peripherally her cap refill time was about 5. She was alert, as I say, and she was able to tell me that she felt dizzy. And to me, she looked really scared. She had a temperature of 38.5, red eyes, no discharge, fine rash on her arms and dry, cracked lips. But while I was assessing her, my fab SHO was cannulating her, there were definitely tears present during cannulation. So with 2 points of IV access, we were able to give her her first fluid bolus of 10 mils per kilo of plasmolite and her ceftriaxone simultaneously. Her A and B didn't initially need any support, but over time she started working harder with her breathing. So we gave her some oxygen via a face mask. As that cannula was being put in and my assessment was being done, 12-lead ECG was done. Bloods were sent off to the lab and a gas was run. Obviously in real time, those bloods take a while to come back and the gas is fairly speedy, but not immediate. So while we're waiting for the gas to be run, we'll just have a look at her 12-lead ECG, which you can see in front of you, confirms that tachycardia of 143 in a girl who by this point I'd found out was 11. So tachycardic, and then those ST changes in the inferior segment. By this point, her gas has come back. Bloods aren't yet back, but looking at that gas, you can see that raised lactate and that low sodium. So started to think about a second bolus, and should that second bolus include some hypertonic saline. Once her bloods were back, as you can see, they showed almost uniformly raised inflammatory markers. Now, I'd argue at this point, while her fluids were going through and her antibiotics were going through, that D, as that A to E assessment and management, should also include discuss and discuss early. And I was in that privileged position being in a tertiary centre in working hours, so had ready access to my Paeds ED consultant, paediatric ID team, PICU on site, and our CATS retrieval team. And all of them were discussed with, and all of them added to the management plan. And our management plan changed from the fluids and the antibiotics and evolved to that recognition that although we'd seen a slight response to that first fluid bolus, when I say slight, I mean about 10 beats per minute improvement, she was unlikely to be entirely fluid responsive and may well need early inotropes. And that recommendation to be ahead and anticipate at all times, start drawing up those inotropes. I'm going to, in a minute, discuss how we made our choice with the inotropes, and I'm not going to go into detail about that because I think Elise is going to touch on that, but just talk about it from the ED perspective. We discussed with PICU whether or not we should include some hypertonic saline, and it was felt that given she was entirely neurologically appropriate, we should hold off on that. We don't want to correct that too quickly. And following discussion with ID, we of course added in clarithromycin, methylprednisolone, and anticoagulated her with tinzaparin and aspirin. We prescribed the IVIG, but held off on it at the time initially because to stabilise her blood pressure and actually to gain some more access. Looking briefly at the discussion about choice of inotropes, I'm sure many of you have seen the CATS emergency drug calculator, and I've highlighted the section about vasoactive drugs. Remember, at this point, she just has peripheral access, and the calculator emphasises that the drug of choice for peripheral access is adrenaline. And so that's what we started her off on. With that, within about 10 minutes, we saw an improvement. Her systolic blood pressure started to increase. But despite that, her heart rate stubbornly stayed pretty much between 135 and 145. Her repeat gas showed almost doubling of that lactate, just to below 10. And she started to complain of central chest pain radiating up to her neck. A repeat ECG at that point showed evolution of those ST changes we saw earlier. So further discussion with CATS, it was decided that in light of the worsening gas, the resistant heart rate and the chest pain, we would add in some peripheral noradrenaline. Which, and I just want to flag up, that did raise a couple of concerns amongst the team, specifically actually the team who had the team members who had the responsibility for drawing up that infusion, that on the calculator, those central concentrations, and is it appropriate to be giving a central concentration via peripheral access? But after some kind reassurance from the CATS consultant on call, for which I was very grateful, yes, we started that peripheral noradrenaline. And with that on board, we were able to wean down her dopamine gradually, aiming to maintain that blood pressure, the systolic of above 100 and the MAPS of above 60. We obviously treated her chest pain with Oromorph as well simultaneously. While all of this was going on, cats were bed finding for us, and we were pleased to hear that a bed had been found for her in Picu at Gosh. So we started preparing for transfer there, which is exactly actually what I'm going to do now. I'm prepared to hand her over and this presentation to my colleagues in ID. But before I do, if I could just share a few learning points that she, to me, really highlighted. It would have been very, very easy to be falsely reassured by how well she looked. She walked into ED and she walked herself around to resus. I can't imagine how difficult it is to assess children like this over the phone, like our colleagues in primary care do, and hats off to them. The idea terrifies me. To me, it highlights the real importance and the luxury we have in secondary and tertiary care of a heart rate monitor and a blood pressure cuff. So please, please, please use them, because without it, I think I could have easily made a mistake and been falsely reassured. She really benefited from early discussion with experts, whether that's local to you or in your network. And just to end on the point, she looked terrified. She was alert and following all of the discussions. And when we said she was being moved to another hospital, she said, that means I'm sick, doesn't it? Now, to have to get your head around that age 11 and watch yourself being echoed and discussion about whether there's cardiac involvement must be terrifying. So I think for those of us who are looking after these patients, when they step down back to the DGH, just bear that in mind, that they might need some help unpicking their experience. Thank you very much.
Hi, I'm Liz Whitaker. I'm one of the Paeds ED consultants at St Mary's Hospital, and I'm just going to very briefly run through how these children present to A&E, and thanks very much to Emily for that presentation of a child who's at the very severe end of the spectrum. So don't panic, they're not all that bad. And just to say where we are currently in London, this is a graph that the French produced last year, but it really highlights what happens in terms of when PIMS appears. The orange line shows when the peak of adult hospitalizations occurs, and the bar charts show when the children with PIMS are. And to be honest, we're somewhere over here around the 2nd or 3rd week in May equivalent. And I think our busiest couple of weeks have already come and gone, I'm hoping. But I do know that the rest of the country are behind us in terms of their COVID trajectory. And so PIMS will continue to be a feature for paediatricians for the next few weeks. And they're following the initial presentations in April, both the UK, the WHO and the American CDC developed guidance, which you can go and read at your leisure. But in summary, these children with this multi-system inflammatory syndrome often present with fever, all have fever, but then may have symptoms of rash and conjunctivitis, abdominal pain and diarrhea and vomiting, and quite often headache and confusion and lethargy. They have quite specific lab biochemistry, which I'll go into, and it really is a diagnosis of exclusion. There are lots of other things that we really need to consider in children presenting unwell with fever, as you well know. And the background of care is supportive, plus or minus immune modulation. I think we're still learning exactly which immune modulators might be useful, but really key, as Emily highlighted, is those early discussions with the rest of the team to decide how best to manage these children. And that's because a proportion, about 1/3 of them, go on to develop shock and myocardial dysfunction with associated ECG abnormalities, and a very small proportion, perhaps less than we think, get coronary artery dilatation. I think that's because there is a little bit of overlap with Kawasaki. There are certainly young children with Kawasaki who are presenting with a little bit more shock than we would be used to. And then this bowel inflammation, which I think is a real marker of these kids, and which Simon's very kindly going to comment on as well. And so the 3 main phenotypes that we saw, that we described back in last year, were the shocked cohort like the patient Emily presented, who often have abdominal pain and diarrhea and don't always have redness at presentation, but if they do, it's quite often they have very, very red conjunctiva of their eyes. They have raised inflammatory markers, and that group who get worse get raised cardiac enzymes and have abnormalities found on echo. We've not had any children this surge have to go for ECMO. I'm going to touch wood there very sharply. And we've had no deaths this time. There was one death in the last surge. Then there's a group of children who present more Kawasaki-like, and their management should be along your local Kawasaki guidance. They tend not to be so shocked. And then there's this other group, which I think everyone's a little bit worried about missing, where they're febrile and inflammatory, but not obviously or overtly shocked. And not necessarily meeting the criteria for Kawasaki. So they may have some tummy pain and diarrhea and some redness, and they may go on to become shocked. And I think this is the group that we're all quite keen that we give good safety netting advice to, or that we pick up when they do present to A&E and it's not clear who they are. So we'll try and talk about those. The Americans see the shock and the Kawasaki, but they also describe a group of older adolescents who are quite obese, who've got significant respiratory symptoms. And we have seen a few children like this who come in with the fever and the rash and the red eyes and the tummy pain, but also with an oxygen requirement. And again, these would just want to be discussed with ID and CATs, depending on how severe they were. And just a reminder of what Kawasaki looks like, although I'm sure you all remember, and this figure on the left, which shows the difference between Kawasaki and PIMS, which is the red features are Kawasaki, so red eyes, red lips, lymph nodes, rashes, and then heart findings, which are mostly the coronary artery dilatation. But in our group of children, they're not uncommonly confused or having headaches, and they have much more significant ventricular dysfunction and shock, so this myocarditis or myocardial stunting, and the vast majority of them have some kind of digestive involvement, so gut inflammation, which we'll talk about in a moment. And how do they compare really to other febrile illnesses? And this is just some data from the consortium that we have at Imperial, showing some of the markers like platelet, CRP, lymphocyte count, and age in comparison with a variety of other febrile illnesses. And these children are much older. They tend to have much lower platelet counts apart from malaria. They have a much higher CRP than most of the other febrile illnesses. And they have this really interesting low lymphocyte count. And as well, they often have high neutrophils. So I think this is quite useful in trying to pick them up in comparison to others. So when do we think you should think about PIMS? So not all febrile children, but in a febrile child who's got kind of out of the ordinary abdominal pain and diarrhea, or who has mucocutaneous features like red eyes and rash. And at the moment, we're suggesting that you might have a lower threshold for doing basic bloods on these children than you normally would. And probably in the first instance, there's no need to go mad with the D-dimers, but just to do a full blood count and a CRP, because if you're seeing this pattern of low lymphocytes, low platelets, raised neutrophils, and a raised CRP, it may then be worth considering doing further investigations. And as Emily said, these children have warm shock. From the end of the bed, they don't look shut down, so they really need a close assessment. And if their bloods are normal, it is just worth making sure the family know if, when and how to seek medical attention. I'm really keen that we don't forget all the other things these could be. If we are thinking that these do have PIMS, we have this PIMS care set, which is on the college website or has been shared through the North Thames network of further bloods. But I think at this point you would be discussing that with an ID team or with somebody else who would also be able to advise you about bloods to do. Really key that we don't miss other viral or bacterial causative pathology, and so all of those samples need taking. An ECG at the very least in A&E, and if there is easy access to echo, it can have value. And then as Simon will go on to explain, imaging may play an important role in those kids who look appendectomy-like, but aren't quite fitting the skill. And what's really key is don't worry so much about specialist treatment, but supportive care, fluids, antipyretics, inotropes with guidance from our wonderful CATS colleagues, and giving antibiotics. So we give clindamycin to protect against toxic shock, because it's very difficult to tell toxic shock from PIMS from the end of the bed in a red child, and it turns off toxin production. And we use ceftriaxone. And again, this is something where we're really happy to take calls and reassure or advise on further investigations. And I'm just going to finish there.
So just a reminder, we'll come back to questions at the end and I'll let Simon move on to his presentation.
Thanks, everybody. I'm Simon Clark. I'm a paediatric surgical consultant at Chelsea and Westminster, and I'm joint surgical lead for the North Thames Paediatric Network. And really the question I think surgeons wanted to know is, should we be thinking differently? And I thought we'd start with the key message really take home is that we surgeons should be having a low threshold for cross-sectional imaging in cases of the questionable paediatric acute abdomen. And the background for this really is that a lot of these children are presenting with PIMS-TS with abdominal pain, vomiting and fever, which is kind of our bread and butter symptoms prior to assessing an acute abdomen. And early on, the first case series that were coming out of the UK, Italy and Switzerland had many children who with an acute abdomen who were positive, and 5 of those actually underwent exploratory laparotomy. And the message started to get out. Next slide, thanks. And in London, in May 2020, there were 8 patients over a very short period who were referred to a tertiary centre for surgical review, and they all had an initial diagnosis of appendicitis. And their CRP elevation was also raised, as you'd expect, in a fairly good going appendicitis between 200 to 400. Some of the symptomatology did not quite fit in with that, all except one. And you can see here on that they all underwent imaging of some sort, and either an ultrasound, which here shows lymphadenopathy and inflammatory fat in the mesentery, almost like a mesenteric adenitis. And on the CT, inflamed fat, and you may be able to see where the arrow is, and actually a non-inflamed appendix. So they're very much presenting with all the typical signs of pediatric appendicitis, and would score quite highly on the pediatric appendicitis score. Next slide, thanks. And only one of those patients actually went on to develop a full-blown systemic inflammatory response and was on ITU. 6, the majority of those were COVID PCR test positive, and the majority were from Black and minority ethnic groups. Then in Liverpool in September, they reported another couple of interesting cases. One was a 14-year-old girl, again, very typical of acute appendicitis, with all the typical high scoring on the pediatric appendicitis score. This time, in her story, her mother was a healthcare worker who was symptomatic for COVID, but actually hadn't been tested. And on examination, as I say, clinically, she was very much appendicitis. She had a high CRP, sometimes in the 400s, around the 400s, and this can be seen in many of the patients. But she had a lymphopenia. They proceeded to do D-dimers, ferritin and transaminases, all of which were markedly elevated. Of course, we don't usually do that in the investigation for appendicitis. 12 hours later, she had the typical rash, Palmer rash that you have seen in inflammatory symptoms such as PIMS-TS or Kawasaki, and her CT abdomen was normal, as was her COVID screen. And she recovered with antibiotics and the interleukin-1 antagonist. And a week or so later, she developed coronary artery ectasia. Next slide, thanks. They then had a subsequent case, a 3-year-old who had another typical 4-day history leading up to symptoms and signs of appendicitis. The ultrasound was normal. Once again, he had a high CRP. His D-dimers and ferritin were raised. By now, they're starting to routinely take these as investigations. But his COVID his COVID swab was positive. They started IV antibiotics and were considering the interleukin. And a PIMS-TS diagnosis was made. However, 12 hours later, he started to deteriorate, had worsening pain and vomiting. The CRP got a little bit better, as it does if you're treating appendicitis with antibiotics. And then the abdominal CT was taken, which showed perforated appendicitis. And more recently in South Africa, they've started to collect all their cases, and they had nearly 80 cases of PIMS-TS, of which 4 of whom had had surgery for appendicitis. All had clinically positive signs for appendicitis and confirmed at operation and on histology. And they're coming to a possible assumption that either is this just coincidence, in that the cases of COVID positivity with the South African variant are much more likely in children, and therefore you're going to be get your relatively standard appendicitis incidence, or are we seeing a new cause for appendicitis where you have inflammation of the small bowel and the appendix? And we know that in Kawasaki that does happen. So 3 messages really. The key one, I think, is having a low threshold for cross-sectional imaging, and Children who are positive may still have appendicitis, and wherever possible, that surgeons and paediatricians need to manage these children jointly. Thank you.
Good afternoon. My name's Elise Randall. I'm one of the paediatric intensivists with the Children's Acute Transport Service in London, covering paediatric intensive care transport for children in the North Thames and East of England area. And I also work on the Great Ormond Street PICU. So I've been asked today to talk to you about which PIMS-TS children require transfer to the paediatric intensive care unit. I'm going to cover what we saw in the first wave, which children we've actually transported. So I'll give you our up-to-date numbers of what we have transported already into intensive care, what we now currently are thinking about how to triage which children need moving, and then an approach to the child that requires a move to PICU. So this was our data back in the beginning. So back in March, you can see along the x-axis the dates. And in blue, the first few cases we had with COVID were the pneumonias, the respiratory distress, and they were in children that generally already had a risk factor from a respiratory point of view. And that was back in March. And then beginning of April, we had a few babies with apneas that looked almost like RSV, but weren't. And we had some fitters. And then the 13th of April, we got our first child that might be a hot shock, so a warm shock, a vasodilatory shock. And you can see in green, we had appendicitis, septic shock, Kawasaki, toxic shock. Those children started to be referred through April and May. And subsequently, as Liz has already mentioned, we had that warning and the diagnosis of PIMS-TS was born. And if you look at our data from the first wave, you can see that PIMS-TS was the predominant diagnosis for the children moving into PICU with COVID. There are over nearly 2/3 of all the children with COVID that moved to ICU had PIMS-TS during the first wave. And as Liz said from the French data, this is London, and you can see the orange plot is the adult cases, and you can see lockdown happened there in March, and the blue columns are when we saw PIMS-TS in London. So there is about a 2.5 week lag, and then we see the PIMS-TS echoing that wave, obviously with far lower numbers, the y-axis on the left side of the screen are the numbers there. So current data, so I searched the database at CATS on Sunday, so that's the complete week up to Sunday that I'm now going to present. It's possible that there is underrepresentation at the beginning of this because we weren't being that this diagnosis didn't exist. So we are retrospectively reviewing our March-April data at the moment. So it's possible we may end up with a few more cases when we've been through them retrospectively. But currently, these are our numbers. So in the first wave, you can see we peaked in May last year. We had a total of 33 PIMS-TS cases moved into intensive care, and we had 0 in July. So that truly was the end of our first wave. And then it grumbled in the summer. And then you can see that we had this massive jump up, jumped up in December, and then we really felt it in January. And February, that represents only 1 week of February. So you can see that we're going to have a lot more than that. 58 patients up till last Sunday were transported into ICU in the second wave, and in total we've moved 91 patients with PIMS-TS into intensive care so far. That was from Sunday, although I can tell you we've moved another 6 since then. I thought it'd be interesting to look at this week by week through the second wave to see if we are genuinely coming down yet, and you can see towards the right hand, this is dates across the x-axis, and towards the right hand you can see that last week we moved about half of what we'd moved the previous 2 weeks. But we've already had 6 this week and it's only Thursday, so we'll see. It may be that we're in a sort of slightly slower decrease than what it looks like on this graph. My region is London. I know that people are going to be watching this from different areas of the country, but from what we see children presenting from the east of England, east of London, and then moving across to the west of London every time we have one of these waves now. So that's quite an interesting phenomenon. And you can see, obviously, there's more children in the second wave. And at the moment, the east of London is more represented, but that may be because we're still at the beginning of that second wave. They are usually 7 to 11 years old. The average child will be 9 years old that you're going to see with this, but you can see there is a spectrum, and we've got about 13 children now under the age of 4 who've been referred and moved with a diagnosis of PIMS-TS. So it can happen throughout our paediatric age range from 3 months up to 18 years is what we've seen, but majority are going to be 7 to 11 years old. And comorbidity, 11 of our 91 patients have had a comorbidity. It is quite wide ranging what that comorbidity is. There isn't a trend to one sort of subset being prone to this. and it's a roughly 12% of the children that are going to have something. The vast majority are normal children with no medical history. And this just shows the purple columns are what we had referrals as, which ultimately ended up as PIMS-TS. So you can see there was that wide diagnostic variation as to why the child was sick in the first wave, because this was a new entity. Even now, though, in the second wave with the orange columns there, we're still getting a reasonable number of referrals as sepsis or septic shock or Kawasaki or lower respiratory tract infections that ultimately end up with a PIMS-TS diagnosis. So it is still a difficult diagnosis to hone down. When we're transporting the children to ICU, the first wave is on the left of the screen and the blue is self-ventilating. So in the first wave, most of these children initially got diagnosed as shocked, possibly sepsis, and were getting treated as the surviving sepsis algorithm, getting 20 per kilo, 20 per kilo, 20 per kilo, which ultimately then leaks into your lungs and requires you to have respiratory support. So in the first wave, initially, a lot of the children were needing respiratory support, and 30% in total ended up ventilated, 70% weren't. And you can see in the second wave that practice has changed. We are more aware of this diagnosis and how to manage it. And actually, these children need less of that initial fluid bolus resuscitation and more vasoactive support, which is why we now have 90% self-ventilated. And these are the vasoactive drugs that we're using on transport. So in the first wave, you can see more than half actually were not on any vasoactive support. And we've got percentages up the y-axis there. The reason for that was when this diagnosis first happened, the first few cases, we knew there was some that had significant cardiac involvement and coronary aneurysms and concerns around arrhythmias. So all these children were being moved into an intensive care unit and assessed from a cardiac point of view, even if they were not on any sort of organ support initially. Now we're moving less of those. The ID wards are taking children directly that are not requiring intensive care. So we are seeing less of those referrals. You can see there's still 40% of children who are not on any vasoactive support. Most of those are going to have risks of cardiac disease that are being moved into ICU because it's a more monitored area before then stepping down, or potentially renal disease that might need filtration and then stepping down to the ward. But there are 60% that are requiring vasoactive support. And you can see, somebody's already mentioned NORAD, Emily, I think at the beginning, and I'm going to talk about that in a moment. But you can see in the first wave, we had 7 children on adrenaline, 2 on noradrenaline, and 6 on both inotropes, adrenaline and noradrenaline. And that's more because we were following our normal sepsis algorithms. Now we know more about this presentation and the fact that usually we're seeing vasoplegic, dilated, warm shock. We are using a lot more NORAD peripherally and NORAD generally. And you can see about half and half are needing NORAD or adrenaline, and then there's 3 patients who've still ended up on both inotropes, and some of them can be resistantly hypotensive. So who are we moving? I've said initially we moved pretty much all PIMS-TS, but now we're moving the children that need organ support. So if they are requiring non-invasive or invasive support, they need to move to a PICU as always. But cardiovascularly, if they have hypotension that has either had multiple fluid boluses and is still resistant or is requiring vasoactive drugs, those children go to ICU. Any child that's got arrhythmias, any child that's got ischemia on their ECG or is suggested strongly by their bloods, and any child that's clinically got cardiac failure, they are felt to be high risk and we put them into the PICUs, and if necessary, then step them down later. Any child that has got significant renal failure, particularly with high potassiums who may need hemofiltration, and then neurology. So a lot of these children have mild encephalopathy on EEG, when you get them into intensive care. And if the child has significantly compromised neurology that is needing airway protection, then they need to be tubed for that reason. And then we have seen some severe DKAs, but that tends to be COVID rather than PIMS-TS patients. So really, the approach I suggest is it PIMS-TS? And in the first wave, that was more of the issue. And now in the second wave, is it anything else, so that we don't miss things like ruptured appendixes, group A strep sepsis? If you think it's PIMS-TS, Liz has already highlighted that the ID team is a first port of call. But if for any reason you think the child needs PICU and needs some sort of organ support, ring your PICM, your Paediatric Intensive Care transport team. CATS covers the North London, South Thames Retrieval Service covers South London, but every area of the country has a Paediatric Intensive Care transport team. You can find it through the Paediatric Intensive Care Society website and call your team if you don't know who they are. They all have conference facilities and they can conference in infectious diseases, cardiology, or any other teams that are required to make decisions for that child, and they can facilitate the PICU transfer. So I thought it might be useful to just summarize the standard presentation that we're getting referred mostly. That's going to be a 9-year-old, mostly boys, about 2/3 boys over girls, previously well, usually self-ventilating, and usually you will have given 20 mils per kilo, and either the blood pressure will have marginally improved or it will be resistantly still the same and hypotensive. And you're looking at a flushed red child who often has a swollen face, swollen eyes, warm peripherally, cat refills sustained, but the blood pressure, the systolics are often 50 to 70. So really very hypotensive, but compensating somehow neurologically. And you're usually referring, saying they need vasoactive support. This is our average referral. So I would say get the cardiac monitoring on and make sure there's a defib available. And this is, I've just highlighted on the right of the screen, the guideline that we now have on the CATS website, and I'll put the website on the last slide that you can read through, which I'm basically now going to take you through some of this, but all of the information is in that guideline. I think when you've got this resistant hypotension, what we want to know is, do you think the cardiac system is compromised? So assess it clinically. Is there any signs of heart failure? Assess those investigations, the ECG, the chest x-ray for cardiomegaly. If someone there can do an echo, obviously that's ideal. If they are the bigger size of child, then the adult cardiology team may support you, because what you're really looking for is functional assessment. They are still going to need a proper echocardiogram looking for the coronaries and any aneurysms. But from our perspective of what drug we want to start, from a vasoactive point of view, we want to know if the systolic function is good or not. Troponin, CK, and BNP looking for the blood's evidence of cardiac compromise. If there are signs of fluid overload, go straight to vasoactive drugs. If there are not signs of that, then you can potentially try another 10 mils per kilo of fluid and reassess. But you are going to be talking, hopefully, to the intensive care transport team, and they are going to need moving. And just quickly, this is a very vague sort of touch on version of this, but essentially, if the heart function is still working on echo, so if you've got sustained contractility, then you don't need to add in inotrope to help with the contractility, and you don't need to make the heart rate go faster, because if the heart is already squeezing well and has a decent rate, you are going to have a decent cardiac output. If it is not doing that, adrenaline is your first choice drug. But most of these PIMS-TS children, actually the function is sustained, the heart is working, but they have got vasoplegia. So the smooth muscle in their blood vessels is not working. They are dilated, their diastolic blood pressures are very low. And what we need is vasoconstriction, which is why NORAD is becoming a much more popular drug for managing these children and why we're using it so much more than we ever were before. And just on the right-hand side there, that is a diagram of what I've just said. So up and down the y-axis, you can see that NORAD gives you good vasoconstriction. But if you are worried that the heart is not pumping properly, if you vasoconstrict and increase your SVR, your systemic vascular resistance, and your heart is struggling to pump already, your heart potentially is going to be knocked into failure. So if you are worried about the function of the heart, then you may well need to, if you need to squeeze, give some inotropy as well with a little bit of adrenaline, which is the children that end up on both of those drugs, or you may just start with adrenaline, make sure the cardiac function is okay before you then add in anything else. Any discussion about this child is going to need intensive care, so ring your intensive care transport team and we will guide you through this and we will help with that decision making. We now have that guideline which mentions noradrenaline, so that is there to support people when being asked to make this up in any of the other hospitals, but do have a conversation with us so we can make that decision with you. I've already mentioned why echo is helpful, and do watch for an increasing requirement and need for respiratory support, because if the child is starting to work harder and it looks like they may need to have some non-invasive respiratory support, it could be a sign that that left ventricle is starting to fail and that the cardiac system needs more support, but also that we need to make sure we move that child into intensive care, even if at that point they're not on vasoactive drugs and it is just that increasing need for respiratory support. And this is just off of the CATS website. You can place, you need to put the patient details in when you use this for real, date of birth and weight. And what we are recommending, as Emily pointed out, there is a line on there for peripheral adrenaline. We are suggesting using exactly the same dosing for noradrenaline. It's in the guideline. It is not yet on our drug calculator because this has to go through our Drugs and Therapeutics Committee, and that does take a little bit longer. But we do have our guideline to support you, and obviously we have a recorded line. You can have that discussion, so that is there to support you with the decision making. But that is how we would suggest administering the noradrenaline. And the other thing to say is if you are struggling to get peripheral lines in or you're not happy with your peripheral lines, we as a CATS team have also been putting in IOs with local anaesthetic and running noradrenaline via that site, because it's still probably the vasoactive drug of choice in these vasodilated children. There are other issues with transport. Our times are slightly longer with all the PPE and the security escorts that we need now, and deep cleaning. Communication's an issue, and parents. We are still taking a parent, but only one parent, and they have to be asymptomatic from a COVID point of view and wearing a fluid-resistant mask. And I think this is my last slide, which one of my advanced nurse practitioners basically sent me that photo as soon as I mentioned that I was doing webinars on this. When you are starting peripheral inotropes or any inotropes, when you make up the infusion, please put 3-way taps at the bottom so that we can use different infusions and titrate them against yours. So that is her top tip. Make sure you're on cardiovascular monitoring every 15 minutes and watch the sites if you're using peripheral lines. We have not yet, we've moved 91 children, we've not yet had a problem with this. But obviously you need to be observant for that. And make sure you tell the child what's going to happen. We're going to hopefully get a video on the website soon of what actually happens if you're lying backwards on a trolley and being wheeled through a hospital into an ambulance and everybody's masked up in PPE, because it is quite scary. So please try and warn them what's going to happen so they're not surprised by the process. It's also freezing at the moment, so we do try and counter that as well with coats and things. Tell them that one parent or relative can come if the parents are symptomatic, and warn that the parents have to wear a mask. That is non-negotiable. And if you can, please get a rapid COVID PCR result back for us, because it makes it much easier to place these children in intensive care. And that is it. I've put in the nice diagram of the cases in adults falling. As we've mentioned, there will be a couple of weeks lag behind your adult peak where you will still be going up on your PIMS-TS cases. But hopefully London's about to start coming down, or is coming down this week. So fingers crossed. Thank you very much.
Thank you, Elise. So if I could ask the panel to all turn on their cameras so that everybody watching can see. Everyone who's given a talk has already introduced themselves. In the interest of time, I will quickly explain that we also have Dr. Hermione Lyle, who's a Paeds ED consultant from Mary's, and Dr. Alistair Bamford, who's a Paeds ED consultant from Great Ormond Street. And we do have Rob Stellman, although he's have to run off to resus, so he may or may not be able to join us for the panel. And we have Fran Clough, who's a consultant from Mary's as well. I'm going to just run back through some of the questions that have already come up during those talks, and then we'll see if anyone more come up during the Q&A session. So the first question was going back really to the ID specialist. It was about Emily's presentation and the height of the troponin and how high the troponins were. So I don't know whether one of our ID team would like to talk about the troponin profiles they're seeing in the PIMS-TS.
I'd just like to say that in the first wave, we tried to design a kind of referral pathway, which Elise did mention, about which children we felt were safe to stay in the DGH, which children needed to come to an intensive care unit, and which children needed to come to an intensive care unit where they might be able to get on-site cardiology and ECMO. And I'm glad to say that in the second wave, we're seeing far less children who are presenting with such severe cardiac compromise needing ECMO. And I think that's partly because people are recognizing things earlier and everybody is getting on top of this a bit sooner. We saw some children who had troponins even up in the 10, 11, 12,000. And we see quite a few children who have troponins of 50, 60, 100. So I think if you see in that very high range, you need to be worried. But a lot of them have a sort of low level of troponin. Very few of them have got elevated BNPs.
Thank you very much. Liz, did you want to come in there? You were gesticulating.
I was just waving. I forgot I was on camera. But I think that the troponin and the BNP tell you slightly different things in terms of myocarditis versus heart failure in a little way. And so I think that's why we measure them both. They give slightly different information in terms of severity. But the troponin going up certainly tells us that the heart muscle is very unhappy. And those children, particularly when it gets up to the thousands, definitely need to be going somewhere else, in my experience.
Thank you. And then our next question was actually on a very similar line. So again, I don't know whether Alistair wants to pick it up, was about the D-dimer change. And so the specific question was, is the D-dimer change that you're seeing specific to COVID, or is it more of a general inflammatory marker and less helpful in terms of deciding whether this is PIMS-TS? I'm paraphrasing.
Yeah, so I've got less and less faith that you can conclude anything from a D-dimer in these patients. It is quite... We are seeing a lot raised and quite significantly high, but it doesn't seem to correlate with degree of sickness. And also, we just never have measured it in unwell patients with fever, inflammation, shock before, so we've got nothing to compare it with. So you can measure it 1 hour and it will be one result, and then 2 hours later it's a totally different result. So it's kind of very low down on my list of prognostic or diagnostic markers.
Yeah, and I would add to that because we get a lot of calls saying we have a child who looks completely well and all the bloods are normal apart from the D-dimer was 3000. And my question is why, just don't worry about it. It's kind of something to take alongside the other bloods, but on its own, it's really very meaningless. And if you fill the bottle slightly inaccurately, you get a very high result. So it can be helpful as part of a pattern, but in its own right, please don't be making clinical decisions around it.
Thank you. Hermione, did you want to add something?
Well, I just think an interesting finding is that the sickest children seem to have very high fibrinogens, which, I mean, up at 8 or 9, which is not what we see in children with DIC who often have a low fibrinogen. So it's a bit odd, this very high fibrinogen. And that often goes along with low platelets and a low albumin and a low lymphocyte count. And I think those are the things that sort of make us more worried. But what you often see is that the first blood test actually looks relatively normal. And it's the second one, maybe 12 hours later, where everything has kind of begun to crash. I don't know if others would agree.
Thank you. I'm going to move us on to a slightly different topic. So this one's more for Simon, but also for our ID colleagues, which is a discussion around the prevalence of possible torsion as a differential in PIMS-TS. So I don't know if you wanted to come back on that, Simon.
Yeah, I think there has been a report in the Journal of Paediatric Urology, actually, where one group did report a doubling in their cases of torsion. It's hard to try and understand that when there is it's a testicular torsion, not an inflammatory episode, but it's possibly that it's a pediatric, it's better reporting of these pediatric torsion cases. But it's certainly something I think we're all monitoring very, very closely. Yeah. Outcomes, I think, is probably possibly even more of a hot topic as to see whether or not the pandemic has affected our torsion outcomes. Thank you.
Alistair, I think you had your hand up there.
Yeah, just anecdotally, I don't know if they've seen more cases at St Mary's, but we've had 2 or 3 with a sort of clinical epididymoorchitis as part of their PIMS presentation, and their imaging was and examination was consistent with that. But again, it's very anecdotal.
Yeah.
And just following on from that, somebody's just asked if you would recommend doing additional investigations for torsion.
No, not really. The message is always a torsion needs to be excluded with an operation because scans are just not reliable. However, if there are other symptoms and signs of PIMS-TS, then that's a different matter.
Thank you.
I think that torsion is probably one of those diagnoses we'd hope people didn't forget because they were worrying about PIMS as well. So I think that's probably also the message.
Thanks, Liz. The next questions were about the rashes that were being seen with PIMS-TS. And I just wonder for those who are in ED, so I'm thinking here particularly Fran and Rob, and then perhaps our ID colleagues, what sort of rashes people are seeing with these PIMS-TS cases?
Shall I start? I think a mixed bag, really. I mean, it's similar to the Kawasaki picture, isn't it? It's just this general feel of inflammation and just unusual stuff. And in any other normal winter, we might just put it down to a viral exanthem. But it's, again, as Liz said, it's about the sort of pattern recognition and the combination of all the different things that then raises your level of suspicion, that then will lead you down to doing some further investigations and or a longer period of observation to see what's emerging. So we've certainly had a couple of children whose initial bloods have been relatively unexciting and then several hours later. So there's, again, you know, as there's so much emphasis at the moment on same day emergency care and trying to keep children out of hospital and stuff, there's just that thing around very good safety netting advice and or a shorter period of observation for those of us who have, or those of you who have their observation units still that aren't taken over by adults or not. But, you know, it's just that thing around making sure that we give people an opportunity to know when to come back and or we keep them that bit longer to pick it up as things evolve.
Yeah, rashes unhelpfully non-specific. So I think a wide variety. So lots of maculopapular rashes in children presenting with the Kawasaki form sort of picture. Sometimes the oral changes, but very variable. Not seeing some things. I personally haven't seen much BCG reactivation even in the older children. That seems perhaps a little bit different from the Kawasaki cases. And there are some things which seem perhaps a bit more idiosyncratic. So perhaps on the milder side of PIMS, or not even PIMS, but on pure COVID infection, just anecdotally in our sector, seem to be seeing a lot of small infants presenting disproportionately mottled, who test acutely positive for COVID on PCR. So I think not a PIMS post-inflammatory phenomenon, perhaps a non-specific reaction to their viral infection, but definitely noticeable. Yeah, I think so. Unhelpfully non-specific is how I would summarize the rashes.
Thanks, Rob. Liz, I'm going to get you to just expand on the rashes, then I'm also going to remind you about torticollis.
Yes, thank you very much. So the rash thing, that the things that are actually really, I think, relatively specific is the really red eyes. And I would say that we see these kids who get the really significant tummy pain and red eyes. And for me, that's a real giveaway. And they quite often have the really classic blood picture. But the other thing that's also really classic is red hands. So if you get children with palmar erythema, that's actually much more likely to be the Kawasaki PIMS end of the spectrum than a viral infection. So it's always really worth having a look at their hands. And some of these children are getting funny little vasculitic spots in their ears as well. So just remember all the funny peripheries where the it's a vasculitis effectively. So that's what we're looking for. And I reminded the panelists to remind me about torticollis. These children have this really strange neck pain. It's not a neck stiffness like you see with meningitis, and they don't actually always have big lymph nodes, but it can be quite a useful finding if they're complaining that their neck hurts. And I'm not sure we completely understand what's going on, but just in terms of other things that might fit with the pattern recognition.
Thanks, Liz. I've got about 3 other groups of questions which I'm going to try and get done in the last 9 minutes. So the first question is hopefully a quick one, which is for Liz, which is around just the clarity of running the NORAD peripherally. So if you could perhaps just review that, because I think that's a couple of questions about that.
Yeah, sure. So we are running it with the same way that we run peripheral adrenaline. So if you go onto the CATS website, you go to the drug calculator and you put in your child's details, the dose for a peripheral adrenaline is exactly the same. We make it up exactly the same way and run it to the same doses as we would with peripheral adrenaline. It is in the COVID guideline because we could get that out onto the website quickly. We're not allowed to change the calculator without it going through the trust's processes, which will take a little bit longer. So we run it the same. We run it, you need to obviously have a good peripheral line in, and if you're not confident in your peripheral line, use local anesthetic, put in an IO and use NORAD that way if you need to. But with any of these children, you're starting any peripheral vaso or central IO vasoactive drug on, please just ring your PICU transport team. And if you're in London, North London, it will be us at CATS. And we'll talk that through with you, make the decision with you. It will be documented on our recorded phone line and you can reference our guideline. We know that it would be ideal to have it on the drug calculator, but that will take a little while before that's available.
Thank you very much. And then the second group of questions, which I'm not sure who wants to pick it up, possibly the ID colleagues or maybe from our PICU colleagues, is around the risks of coagulopathy in these patients, looking at the adult experience of particularly PEs in the context of COVID. And the various questions about whether these children should be getting regular prophylaxis or aspirin. And so I don't know if somebody wants to pick that up.
I think it's a case-by-case thing, and this is something you should be directed by the ID team who are seeing the patients. And I don't think we would recommend that all children in A&E with possible PIMS-TS are being given thromboprophylaxis, and it's kind of going to come down to other risk factors for thrombosis. So generally speaking, with advice from outside colleagues is what I would say. Well, that's why it's not everywhere on the guideline.
Thank you. And I think most people would say we would be starting these in the ED setting, whatever happens. These are going to be discussions predominantly once they've been retrieved to an intensive care unit. I think that's a fair comment. There's no rush to be starting aspirin in the first.
Absolutely not. Oh, Hermione's got her hand up.
Marnie, yeah.
I'm just going to say we haven't really mentioned other kinds of treatments for trying to switch off the inflammation. And at the moment, some of you may know that the recovery trial is going on where children are being randomized to corticosteroids, IVIG as a first line, or standard of care without either. And thinking about whether you can enroll this child in the clinical trial is really important. But I would say that over the last week of the children that I've been involved with, administering methylprednisolone in A&E is really something to think about, because it takes a few hours for this to work. And in the children where we've been able to get this started, within 4 or 5 hours, we've actually been able to turn the noradrenaline off and manage to kind of reduce that problem of the vasodilation. So it's also thinking about what you're doing to switch off. And again, the infectious diseases team can help you in thinking this through.
And just on that note, we will be doing a webinar on the recovery trial next week, which we'll share throughout the network, because actually if we can get people to recruit to recovery and do the training, it's actually very straightforward. It's not as scary as it sounds, and getting people enrolled in DGHs before they get transferred to tertiary centres would be really beneficial. So look out for that webinar, and hopefully you'll be inspired to go and do the very short 15-minute training. Thanks.
Thanks for that plug, Liz. The final sort of group of questions is really about the other end of it. So how can we be confident that we aren't dealing with a PIMS-TS? There's various questions about which are the low risk patients, who do you not need to bleed? Do you need to do routine tests in children who wouldn't meet the criteria or only partially meeting them? So I wonder whether we'd like to try and support people with that. Who am I going to pick on? Oh, anyone.
We're all being very brave. I think this is really difficult, and I think this is why I was saying at the moment, the next couple of weeks, we are going to have a slightly lower threshold for bleeding. I think we've all worked in A&E. There are some children where it's really clear that they're not that unwell, but the things to look, and I know it's impossible, and you are going to possibly end up doing a few more FBCs and CRPs, and I would say just for the next couple of weeks, then you can probably stand down on the anxiety as this has passed. But if they have red eyes and quite unusual abdominal pain and fever, that's the group who I think you might not otherwise always bleed. You might just say that could be a mesenteric adenosis virus. It's probably worth doing an FBC and CRP on that cohort of children, if that makes sense. And I'm sorry that we can't be more prescriptive about that.
I think I'd just add that I've definitely become a lot less brave than I have been in recent years since March time. And, you know, in a normal winter, you know, I'm almost doing SHO level bloods that, you know, thinking back to my early years of training, but it just, because we just don't have that same sense of understanding it as much as we have done with the other stuff that we've been dealing with for the last 20 years, dare I say it. But you know what I mean? So I think that, but as, you know, I'm lucky as well to be guided by, you know, really expert colleagues at Mary's and widely as well. But I think, yeah, for the next few weeks, I've definitely been a lot more risk averse than I have in the past over the last sort of, how long are we into it now, 10 months or something. Yeah. And just with the safety net and advice, but you know, we still managed to get plenty of children who have been hot and tacky better in home, and they've not transpired to have that. So we've not done the full shebang of all the bloods on all these children at all. We've just done some screening bloods with some basic markers and clinical acumen and review, and then depending on what the parents are like, either admit or send them home in safety net and things like that.
Thank you, Rob.
I think just to back up very quickly what
we just let Rob, because he's had his hand up.
Oh,
and
sorry.
I would never interrupt Hermione, so I'll make it very quick. But just to try and say something concrete, although it's very limited, if my co-panelists would agree with me. So firstly, perhaps it's obvious, but I think it bears saying, my understanding is it's now felt that if a child doesn't present with pyrexia, then essentially the likelihood of PIMS is close to zero. So we are talking about pyrexial children. There was previously some uncertainty about that. I think the certainty has improved. Secondly, you know, part of the definition is a prolonged fever. I don't think anyone is able to say yet what that duration is, but my personal practice would be certainly in the first 24 hours of a feverish illness, my threshold for thinking about PIMS is going to be quite high. I'm going to have that relatively lower on the differential. And my third point, just to pick up on something very useful and helpful that Liz mentioned in her presentation, is just about CRP thresholds. So there's been huge evolution around that, hasn't there? In recent months, as we've known more about the condition, you know, the early case series were all quoting CRPs of 150 at the lowest and above, and that's kind of steadily come down in the consensus pathway, kind of close to 100. And I saw, Liz, you talked about 50, and I wonder if that represents us doing a better job picking up these cases earlier on, and therefore naturally seeing lower CRP. So we have to think a little bit about what our CRP threshold is to move on to those second line bloods, and it probably has crept steadily lower, but I will yield the floor to Hermione, who knows much more than I do.
No, Rob, I could totally agree. It's definitely an evolution. So things are progressing. But I was just going to highlight the fact that the epidemiology of infections that are out there at the moment is very different from what we would normally be seeing at this time of year. You know, there are, touch wood, so far there are no reported cases of RSV or flu. We're seeing far less respiratory infections. There is still a bit of group A strep, so that is obviously in the differential. But I think if you have a hot red febrile child right now, you know, PIMS is probably top of your list.
Thank you. I'm aware we've reached 2 o'clock, which is the end of our webinar and the end of most emergency medicine consultants' attention span. So thank you to everyone who has managed to last the full 60 minutes. I'm going to just finish by saying there are a couple of other questions in the chat that have been coming up about sort of more of the inpatient care, when to use various things. I think that's all fairly comprehensively covered in the last webinar that was given. And if you email that email address that's on screen now, we can share you the link for the recording of that webinar that went on last Friday. And then this one is going to be shared after this as well. I would just like to say a huge thank you to all our presenters and to all our panelists. It's hugely helpful when we're dealing with such a new and evolving condition that we can pull so many people together in such a short space of time to help educate and inform those of us who are dealing with this on a day-to-day and case-by-case basis. So with that, very much, and thank you everyone for joining us.